everyone. Myself, Dr. Sakshi, oral medicine and oncology specialist, and I'm truly honored to be here today. A huge thanks to Professor Dr. Ravi Mehrotra, sir, CHIP Foundation team, and Eco India for providing me this opportunity. We'll be discussing today about the oral potentially malignant disorders, an important group of conditions that can precede oral cancer, their types, diagnosis, and management, focusing on their understanding for early detection and better patient outcomes. So, moving on with the hidden threats and why OPMDs deserve our attention. As we often know that OPMDs are overlooked but represent a critical window for early intervention. By understanding and managing them in time, we can significantly reduce the burden of oral cancer and improve the patient outcomes. This slide shows the distribution of oral cancer across the India, and as we know that oral cancer ranks among the top 6 cancers globally and especially prevalent in India also. These numbers underscores the urgency for early detection through oral potentially malignant disorders. So what are OPMDs? These are abnormal changes in the oral mucosa that increase the risk of developing oral cancer, mainly oral squamous cell carcinoma. As shown in the diagram, oral potentially malignant disorders represent an early change in a progression that can take years, from normal epithelium to dysplasia, carcinoma in situ, and eventually the invasive oral squamous cell carcinoma. So, over the time, the terminologies for these disorders have evolved from 1805 to 1978, called as precancerous lesions, to 1978 to precancerous conditions. However, the WHO workshop in 2005 defined oral potentially malignant disorders as on oral mucosa abnormality that is associated with a statistically increased risk of developing cancer. It is untrue that pre-malignant lesion can become cancer. That's why in 2005 it was considered as a disorder. However, there are various other classifications also. So moving on to this, these are some lesion identified as OPMDs given by WHO in 2020. However, some lesions were removed and some were included, like oral lichenoid lesions and oral graft versus host disease. However, currently we will look towards the most commonly found oral potentially malignant disorders like leukoplakia, proliferative verrucous leukoplakia, erythroplakia, OSMF, and oral lichen planus. So, various definitions for leukoplakia have come into view since 1978, 1997, 96. But leukoplakia currently is defined to diagnosis by exclusion by WHO Working Group 2021. The latest criteria of WHO emphasizes its diagnostic features like non-scrapability, well-demarcated borders, homogeneous and non-homogeneous type, including the red and nodular components, persistent features, no other chronic or traumatic irritation to the area, and it does not disappear or fade away on stretching. Exclusion of other white lesions and red and white lesions, as stated previously, is the diagnostic criteria also. So moving on to the types of the leukoplakia, basically there are two types, homogeneous and non-homogeneous type. Homogeneous is typically seen in males between 40 to 60s. It is white, well-defined plaque-like uniform with no erythema present. Surface is leathery with cracked and muddy appearance. Sometimes varicose areas are also seen. This is usually asymptomatic with a high malignant transformation rate can reach up to 34%. However, homogeneous leukoplegia, earlier also known as erythroleukoplakia and speckled leukoplakia. These variants have both red and white lesion. It can also have verrucous, papillary, nodular, exophytic structures. Any other type of leukoplakia along with the white patch or red patch is considered currently into non-homogeneous leukoplakia. While a provisional diagnosis of this can be made visually, but biopsy and correlating the history provides us the definitive diagnosis. Microscopic features like pleomorphism, nuclear changes are the key indicators, and excluding the various differential diagnosis, we reach to a conclusive diagnosis for leukoplakia. Along with this, erythroplakia is a lesion that can't be clinically explained otherwise. It is predominantly fiery red patch and cannot be characterized clinically or pathologically as any definable disease. It is demarcated, flat, depressed, clinically seen as matte or velvety in appearance. It is a solitary presentation and should be differentiated from other type of oral potentially malignant disorders and red and white lesions like erosive lichen planus, lupus erythematosus, and erythematosus candidiasis, which present more often in the multiple sites. However, this most commonly present to a particular solitary lesion in presentation. Though rare, its cancer transformation rate is extremely high, often presenting with carcinoma in situ as diagnosis. Like leukoplekia, erythroplakia is also diagnosed by exclusion. Its solitary, velvety appearance and high risk warrants prompt biopsy and histological evaluation, along with the differential diagnosis of exclusion. Moving on to the proliferative verrucous leukoplakia, which in 2020 defined by WHO Collaborating Center is a progressive, persistent, irreversible disorder and characterized by presence of multiple leukoplakias that frequently become warty in appearance. That is, they have a progressive clinical course, changing clinical and histological features in the oral cavity. Like lesion evolves from one or more leukoplakia and it spreads to other multiple locations in the oral cavity gradually, and individual focus or resulting from the fusion over the time of the several adjacent foci. Hence, also termed as proliferative multifocal leukoplakia or proliferative leukoplakia. This is mainly seen in older women. Most commonly, the location is lower gingiva, but as we know, it is a multifocal in appearance. It initially presents as white lesion and sometimes appear as lichenoid clinical appearance, and later it can also appear as papillary varicose production covering the multiple regions of the oral cavity, hence defining its terminology. Moving on with the investigations, so far the leukoplekias we have covered. Screening tools like Toledan Blue, brush cytology can help, but biopsy remains the gold standard. However, smaller lesions can be excised directly. Various new screening tools have been coming in current practices like laser-based detection system, chemiluminescence, autofluorescence like Visilight, Veloscope, and laser microdetection in the cytopathological studies and various salivary biomarkers. But ultimately, the biopsy remains the gold standard. Moving on to the management, which covers the most priority for it is stopping of the habits, that is elimination and cessation of the tobacco habit, elimination of the traumatic causes, treating any treating any infections involved, and various superadded infections like candidal infections. Throughout the time, as the surface is rough, there are many superadded candidal infections over the surface. So, treatment also includes the use of topical or systemic antifungal drugs, various chemopreventive drugs, anti-carcinogenic, and antioxidants like vitamin A, beta carotene, lycopene, retinoic acid, and vitamin E. These aim to reverse dysplasia or prevent the progression of leukoplakia to oral cancer. In an emerging approach evolves like photosensitizers, light therapy like photodynamic therapy, which selectively targets the dysplastic cells while sparing the healthy tissue surrounding them. A specific source of light is there, which only damages the lesion, and with time, reepithelialization occurs, sparing the normal cells and destroying the abnormal cells along with the reepithelialization. In extreme cases, chemotherapeutic drugs like bleomycin have been under use. Surgical management in extreme cases or in the cases of proliferative leukoplakia like laser ablation and excisional surgeries are also under use. Moving with the next, oral potentially malignant disorders, most commonly caused by areca nut, is oral submucous fibrosis, which is a chronic scarring condition largely linked to areca nut use and affects a wide age group and can lead to significant functional impairment and cancer risk. Its pathophysiology uh, includes the use of includes the presence of alkaloids, flavonoids, copper, and constant chewing. Alkaloids increases collagen formation in the connective tissue. Flavonoids reduce the breakdown of these collagens, and copper disrupts the lysyl oxidase activity, hence increasing the amount of insoluble collagen. And continuous muscular contracture with continuous contracture leads to depletion, fatigue of the underlying connective tissue, and along with the all of these things, ultimately juxtaepithelial hyalinization at the histological viewpoint is caused and continuously causing muscular fibrosis and scarring. So these muscular fibrosis and scarring present both in the early and the later stages. Most commonly, in the first signs seen in the oral cavity would be the presence of petechiae, vesicles, pigmentations, ulcerations. However, in the later stages of the oral submucous fibrosis, progressive increase in fibrosis is there, along with presence of fibrotic bands. J hockey shaped uvula is present. Deep papillated tongue is seen, along with continuous decrease in interincisal gap and decrease in the mouth opening. That is completely advanced case also present as a trismus. So, presence of other OPMDs, leukoplakia, erythroplakia, lichenoid lesions are considered in the later stages, are also considered into the grade 4 oral submucous fibrosis. There are various grading systems given starting since the 2011 given by Kerr. It is only based on the clinical grading system of the mouth opening. However, Khanna and Andrade 1995, this is the most commonly used clinical and functional staging system used in our clinical scenarios based on the mouth opening and the clinical presentations of the oral cavity. Currently, Gupta et al. In 2023 defined clinical, functional, histopathological criteria for defining oral submucous fibrosis, giving its treatment and along with the prognosis of the treatment outcomes based on the grading system. Differential diagnosis for oral submucous fibrosis includes scleroderma, generalized fibromatosis, amyloidosis. So, moving on with the management of oral submucous fibrosis, first of all, stoppage of the habits. along with physiotherapy, which is included in the non-surgical treatments and some of the surgical treatments. Non-surgical treatments include physiotherapy and use of some corticosteroids, which can be topical, systemic, and intralesional. Supplements like vitamin A, C, and E, which help in epithelial repair, vitamin B complex, which improve the neuromuscular function and mucosal lining underlying the oral mucosa and connective tissue. Various minerals like zinc and iron promote immune function, helps in wound healing in the early grades like grade 1 and grade 2. Antioxidants like lycopene, curcumin, and piperin. Oral physiotherapy, uh, along with by the use of ice cream sticks or the over-the-counter devices and retractors, plays a supplemental role. Intralesional injections uh, and various proteolytic enzymes like hyaluronidase, chymotrypsil, all placental extracts has been under use. However, currently the intralesional use of dexamethasone has been given the priority. However, the grade 3 and 4 cases are treated by fibrotomy and grafting. Moving with other toxic reactions to tobacco, like smoker's palate and melanosis, are common finding in the chronic tobacco users. While not all are pre-malignant, they signal the need for the lifestyle changes and monitoring. Oral lichen planus, although it is a oral potentially malignant disorders not caused by any tobacco use or areca nut use, but the knowledge for it is important because it should be differentiated from other potentially malignant disorders. Oral lichen planus itself is a chronic inflammatory autoimmune condition and present with various clinical forms, some of which are asymptomatic ranging from reticular to papular types, and some are painful and erosive lesions. Characteristic feature of this is the relapses and remissions, presence of them on bilateral mucosa, and unilateral cases are also found, but they are rare. It has autoimmune links and can undergo malignant transformation. Moving with the pathophysiology, oral lichen planus is in this the body's immune system mistakenly attacks the cells of mouth lining. White blood cells called T cells are activated and target the basal layers of the epithelium. This causes cell damage, inflammation, further leading to thickening of the surface, leading to white patches seen in the mouth, and in severe cases, they can also cause atrophic areas or erosive areas. It occurs most commonly in middle-aged females, like 30 to 65 years, and is estimated to affect approximately 0.5% to 2% of the general population, and most commonly it is found in white individuals. There are 6 classical clinical presentations: reticular edematous, ulcerative, also known as erosive, plaque-like, and bullous form. Reticular and papular oral lichen planus shows white lesion and white striations, also known as Wickham striae, forms a interlacing or net-like pattern and is a hallmark sign of this. They both present without symptoms and initially papular form can coalesce and form a more reticular type pattern. Moving with the edematous or atrophic type, they are frank red lesions, most commonly present on the buccal mucosa, resulting due to clinical inflammation, autoimmune reactions, and thinning of the epithelium. If present on attached gingiva, the diagnosis to be made is of desquamative gingivitis. Ulcerative form are present with a grayish, yellowish, fibrin-like pseudomembrane overlying the breaches of the mucosa. This is caused due to damage of the basal cell and its loss its integrity with the underlying underlying epithelium and the connective tissue. Plaque-like is often confused with homogeneous leukoplakia, hence, the diagnosis for this is very important relating to the other clinical features. They present as solid patches instead of a net-like patches and most commonly found on the tongue, dorsum of the tongue. Bullous-like are very rare and present along with erosion and ulcerative forms, and they are often misinterpreted with superficial mucoceles and pemphigoids or pemphigoids lichen planus. Moving with the diagnosis given by WHO group in 2020, the diagnosis includes exclusion of systemic causes like diabetes mellitus, hypertension, anemia, and biopsy. We should look for extraoral lesions along with oral lesions, as lichen planus is often present in the skin, scalp, nails, etc. So, moving with the management part, principal aim for current oral lichen therapy is totally based on the resolution of the painful symptoms of the patients. Management is symptomatic, and the mainstay therapy remains the corticosteroid. However, before giving any therapy, we should check for any cause, mainly for the lichenoid drug eruptions, which are often presentable as oral lichen planus. So, management mainly depends on how much grade or severity of the oral lichen planus is. Mainstay therapy is topical, intralesional, or systemic corticosteroids because it is an autoimmune condition. These steroids modulate the inflammation and immune responses, along with various immunomodulators like levamisole. For superadded infection over the roughened surface, and fungal infections are there. So for these superimposed candidal infections, antifungals are used, which can be topical, and in severe cases, systemics are also given. Anti-keratinizing and immunomodulating effect for vitamin A has also its effect on reticular and papular variants. Various selective inhibitors for CD4 cells like cyclosporin and multivitamins are also being used depending on the predisposing factors. However, in extreme cases or the cases uh, which have the high risk of turning into dysplastic areas are often surgically excised and also treated with photochemotherapies using ultraviolet A light with a particular range to 320 to 400 nanometer. So all of these till now were the most commonly observed oral potentially malignant disorders, and their diagnosis, knowing about the clinical features and management is very important so that the further conversion to oral cancer is avoided and early detection is helpful for the patient. So, in summary, I would like to conclude that oral potentially malignant disorders are key indicators for oral cancer risk. Early detection, habit cessation, and consistent follow-up for long-term outcome are the most powerful tools, and we have to reduce cancer burden and save lives. However, biopsy is the paramount for these conditions, underscoring the importance of proactive surveillance in preventing malignant transformation are the results if we continuous do oral screenings, habit cessations, and management for these patients. So, big takeaways from this session would be like managing OPMDs effectively not only reduces cancer incidence and mortality, but also significantly improves patient quality of life and lowers the healthcare cost in long term. Thank you so much. These are my references. Any questions?
Well, do we have any questions for Dr. Sakshi? The house is open for questions now.